So this is a short video on the approach to diagnosis. So the way that I think about diagnosis is thinking about, okay, why is it actually important to be good at diagnosis in the first place? One of the key things here is this quote from William Osler, which is listen to your patients, he is telling you the diagnosis. And what that means is that asking the right questions, taking a very detailed history is actually really, really important to think about the things which could be causing the patient's symptoms and the most accurately treating them. One of these quotes from Ralph Green says that if you can make the diagnosis, the treatment is easy and the damage can often be reversed, but making the diagnosis is tricky. There are considered to be over 1,000 sort of common or relatively common diagnoses which you might need to know about. But the main thing is if you can get to the right diagnosis, there is a lot of material out there now to actually be able to work out what to do about that. So I think that one of the key things being a doctor is actually working out what the diagnosis is and knowing the differences between different diagnoses and how key history examination and investigation findings can impact that. And as Tony Alexandra says, in selling as a medicine, prescription before diagnosis is malpractice. And what he means is that too often doctors don't formulate a diagnosis, don't think about a diagnosis, and actually just start treating the symptoms. If someone comes in with vomiting, they give them anti-nausea medicines. Someone comes in with constipation, they give them laxatives. But it is a key thing to not only think what symptom am I treating, because it's good to make the patient feel better, but actually why is that symptom happening? What is the underlying diagnosis which is causing that? So the rationale for using diagnostic aids like the diagnostic dashboard, which I've created, is the fact that around 10 to 15 of diagnoses made by doctors are incorrect. So that's between 1 in 8 and 1 in 10 of every diagnosis that is made is wrong. Now, instead of more senior doctors teaching more junior doctors systemically, individually, one by one, and trying to impart their knowledge, it actually makes more sense to have quite a systemic solution to this. So have a diagnostic aid or aids so that many juniors, many students and many house officers and junior registrars can actually learn from the same tool. And if that's updated and they're using it, then actually that becomes an excellent source of truth. Now, the major cause of diagnostic failure is clinical reasoning errors, which means premature closure and or failure to consider an important diagnosis. So premature closure is when someone presents with a symptom and you know most commonly that symptom is related to something else. And the main examples of this is dysuria, because most often it is caused by UTI, but not always. There are a number of other diagnoses like STDs, cancers in the elderly, renal colic, which also can cause this. But a lot of UTI, for example, is treated based purely on the dysuria. And the second thing is actually the failure to consider an important disease. So if someone mentions an important disease as a potential cause, people then look into it and they can actually rationally exclude it from their diagnosis. But what often happens, people think one symptom, a couple of symptoms, that's the diagnosis. Don't actually broaden their differential originally, just to make sure that there's nothing else that they're missing. One of those important things, especially if one of those slightly more rare things, is actually missed. And medical school is the right place to start good diagnostic practices. And doctors that haven't used tools like this as they get more senior can become a bit too overconfident once they've qualified, have a little bit of experience, and actually don't tend to use them and don't tend to reflect on their practice as much. So it's a good time during medical school to learn how to use and think about diagnostic practice. And many papers that are out there, internationally validated papers, have said it is best practice to create a differential diagnosis on every case. Now, it might not be the case for everyone because a bunch of them are barn door, but for most cases, it's the right thing to do. And that will be good practice. And it will be good for if you think that you know the diagnosis quite quickly or if you have no idea. Until recently, medical students don't really have a list of a differential diagnosis for each presenting complaint, or if they do, it's from a textbook or it's very one-dimensional. And I'm trying to change that. So this is what the differential diagnostic dashboard looks like. And down the right-hand side in the light blue, there's information on diagnostic theory, which is what this is, how to navigate the website, and also the different views. There is a separate video on how to use the home screen of the dashboard. So the process which I would encourage is actually to open it briefly in the optimal learning view, which is the first view, on the hospital computer or on your phone before seeing every patient. And that can be while you're reading the patient's chart, nursing and ambulance notes. They only take a couple of minutes. Then familiarise yourself with the correct questions to ask down the side, and based on the age, sex, and time frame, which you can click into to actually then re-show you what the most likely differential is. You might just quickly have a look at the important causes and the common causes by highlighting them over 5 minutes, and then you go and see the patient as you normally would, and that just you take as long as you normally want. When you come back, though, I would encourage you to use the diagnostic dashboard on the same view and actually input the answers to the questions, which are generally sensitive and rule out certain diseases, and then just look at what's left. If you switch to the rank view now, it actually ranks the diseases and shows you up to the top 20 still possible, with the higher likely ones at the top. So not only helping you have understood about the anatomy or the civ view of the world, but also by ranking view with extra questions, what actually is more likely. And then if you need to, you can hover on different over different diseases to show more information, to start to think what's more likely and less likely, what's sounding more similar to any of these. And then lastly, you've got the option to use references as well. From all of this, you should be able to make a provisional diagnosis based on a combination of your knowledge and the support of the diagnostic dashboard, and list some possible alternative diagnoses as well. And at this stage, I'd say to you, please ask yourself, how likely is your provisional diagnosis given the symptoms, signs, and investigations? Now, the process here is relatively simple. If you think it's very, very likely that you now know what is going on, I'd briefly just scan the high morbidity diseases on the page and click on it to make those ones that are just highlighted red. If each of those is unlikely, then you probably got the diagnosis and then treat it accordingly, or tell your senior that is what you're thinking. However, if there are 2 or more red flags which pop up, then I would consider discussing with the senior more appropriate investigations to make them more unlikely or rule them out. As your provisional diagnosis you think is less likely, then I would be scanning the rest of the alternative diagnoses just in case something else pops out at you. And if there's 1 red flag for any of those high morbidity diseases, I'd be looking through the investigations. And if you're really not sure, actually, even after using the diagnostic dashboard, and there's a number of things still available, I'd be scanning the rest of the alternative diagnoses, think about further testing, and even without any red flags, think, look, could it be one of these cancers? Could it be one of these vague infectious diseases? And actually sort of think more about those things. The next video will actually take you through a practice case showing you this process I've described.